Hello, everybody. Thank you for joining us. My name is Jo Christie, and I'm the named midwife for safeguarding at Northampton General Hospital. ARM, what is it, how to implement it, and what does it look like is what we're going to be presenting to you today. And as Kath's already introduced herself, and also along with us today is Fiona O'Brien, the Safeguarding Adults practitioner from KGH, and one of our colleagues who has contributed to the presentation but unfortunately isn't here with us today is Margaret Mills, and she's the named professional and safeguarding lead at St Andrews. Thank you. So what is an ARM? So in the simplest terms,
You
it's
want to sit in on this, or are you? I open the ring as well.
Oh,
Hey.
hello. Sorry.
Obviously.
Has everybody got their microphones off? I can hear some talking.
Jo, you're on mute now.
Sorry. Did you hear me in the beginning? Was I on mute initially? No, okay, sorry, I don't know what happened there. I went back on mute. Apologies. So an ARM in the simplest terms is a professionals meeting or a multidisciplinary team meeting. And what makes the difference from any other sort of professionals or MDT meeting is that there is a level of risk identified and a risk enablement plan that's put into place to help manage that risk and to help minimise the risk and to ensure that further meetings are held to make sure that the actions are taken from and support is provided from services and agencies to ensure that's in place and established. Once the risk has been lessened, then the arm can be stepped down, closed. Thank you. So the main point of the arm is the following. So it works with the individual strengths and formulates an action plan for an individual with additional care and support needs for whom there are significant concerns about the capacious decisions that they are making and the impact that this could have on their own safety and also possibly the safety of others. And that could be obviously family members, people within the community, or the professionals that are dealing with them. It's an opportunity to ensure that all agencies have offered support in various different options to an individual whose life is at serious risk of harm. And it identifies within the arm the responsibility for specific actions and a mechanism for review and re-evaluation of that action plan. And as I said, in the order to either remove or reduce, mitigate that risk. It's a multi-agency approach to risk enablement, and it identifies actions for the individuals, including the individual concerned, and agencies, organisations to reduce or remove risk from the individual whilst considering which professional is best placed to successfully engage with the individual or the implementation of the risk enablement plan. So different aspects of the risk enablement plan, different agencies, services will take responsibility for that. So there's not one overriding agency that's responsible. It's, as we said, that's that MDT approach to managing risk. The ARM process can be used prior, during, or after any safeguarding inquiry, linking with the interagency safeguarding procedures. So it does not replace any of those, it just runs alongside them. Thank you. Do I have the next slide, please? Thank you. Sorry. So in order for an arm to be held, the following criteria should apply. So an individual should be an adult, so 18 years and over, and they must have capacity to make decisions regarding specifically the decision that is causing concern. The practitioner should have no reason to doubt the customer's capacity and should state the reasons and provide proof wherever applicable. If there is a query around capacity, then obviously a mental capacity assessment needs to be completed, and that needs to be obviously decision specific. And, you know, arms can be held for individuals who may have fluctuating capacity. You know, for example, if they're, you know, using under the influence of alcohol or illicit substances, that capacity may fluctuate. There has to be a risk of serious harm or death through either severe neglect, fire, deteriorating health conditions, declining to work with services, targeting by the local community, hate crime or antisocial behaviour. It could be sexual violence or decided to decline to engage with a single agency or multiple agencies, or any other investigations for safeguarding. So, you know, it could apply to individuals who have got a chaotic lifestyle, who, you know, are choosing not to engage with services, and, you know, that in that itself is increasing their risk and putting their lives at risk of serious harm. And there is a public safety interest or a high level of concern from partner agencies. Okay. So, definitions of serious harm. For the purpose of the policy, serious harm refers to the death or injury, either physical or psychological, which is life-threatening and or traumatic, and which is viewed to be imminent or very, very likely to occur. Sorry. The definition of social self-neglect, from the Social Care Institute of Excellence, defines self-neglect as having three possible strands. So that could be self-care, a lack of care over personal hygiene, health, nutrition, hydration, leading potentially to severe harm or death. Their environment, a lack of care leading to squalor or hoarding, risk of fire, as we mentioned before, refusal of services which may mitigate harm, such as support with alcoholism or substance misuse, or that you know, very high risk taking behaviour. So an example could be, you know, someone who is street homeless, refusing to engage with outreach services, which could, you know, help reduce the risk that they're exposing to. The Care Act of 2014 includes self-neglect within adult safeguarding, and some self-neglect cases will be managed through the safeguarding procedures under a Section 42 inquiry. However, not every case of self-neglect will meet that criteria for a safeguarding inquiry. The critical factor is that it's likely to be if an individual is able to manage their own behaviour to prevent harm to themselves, then it wouldn't necessarily meet the criteria of an harm. Thank you.
So who should attend be invited to an ARM? It's a question that we quite often get asked. So the main person that we would ideally like to see an ARM is the person who we are discussing. So once you've had that conversation with your individual, ideally we would like them to attend an ARM meeting so we can get their views, their opinions, their thoughts, their feelings. It's really important to capture that at these meetings. So we have adult social care, we have children's social care as well. Ideally, we would like the police to attend, and that can actually be any of the teams that this individual may be known to. But ideally, vulnerable adults team and any local neighbourhood team could attend as well. They all hold valuable information. They can all share information as well. So any of the drug and alcohol services, so ideally S2S. Within health, obviously, we have many strands within health. So your GP would be great. So the individual's GP to attend, or their safeguarding team within their practice. Local hospitals, the safeguarding team can attend. And within that, you have NHFT, the safeguarding teams. Community mental health services, any psychologist, anyone through health that the individual is known to. Housing officers, and again that can extend to many other strands of housing, so the rough sleeping team, you know, anyone that the individual is known to through health should be attending. Outreach support workers, the voluntary sector, we have so many services within our county that your individual could be known to, if we can invite them, because any piece of information is really helpful within an ARM process. If the individual involved is known to probation, invite the probation officer. And then with the individual, it may be that they would like some support through a family member. It may be that they have a carer, or it may even be that they have an advocate. But it also may be that these individuals have their own information to share and to put into the ARM process. So overall, anyone that is involved with the person, especially if they might engage with them or have a positive relationship, so a good rapport with that individual, please invite to the ARM. Any piece of information is helpful within this process. Thank you. So who should instigate the ARM? Any agency, any person can instigate an ARM. Ideally, it needs to be initially the service that has the concern, that has the need for support from other services. So the agency identifying an individual at risk is responsible for initiating, coordinating, and initially leading the ARM meeting. So that includes the actual sorting of a date, collating any partnership comments, and circulating the minutes. Once the initial ARM has been heard, it might not always sit with you as your agency to continue with that ARM process, such as within health, our patients within the hospital aren't with us for long periods of time. So we may not always need to lead that ARM, but we can certainly instigate it. And then the next agency who has the most input and continued input would then ideally be the one to carry on, continue with that ARM. Yeah. So within the initial ARM meeting, it will be agreed as to who will continue the ARM meetings. This relates to when agencies have a short-term input, but the concerns will continue outside of that agency service. And as I've said, as an inpatient in hospital, we have a short window. So how do you instigate an ARM? And I think there's been a few misconceptions about ARMs and how we deal with them and how we implement them. And this is why we did this training session to try and dispel some of those myths. So speak with the individual, advise them of what an ARM is and how it can support them. If this is not possible and consent is not gained, please continue with that ARM process. Establish who is involved with the individual already, what knowledge and input you require to help manage that risk, and involve all those key agencies that we talked about on the other slides, and those that you require that input from. Sending the invites out is as simple as that. Figure out who you want to attend, who you need to attend, send an invite out via Teams to any of those professionals. There's no form to fill out. You don't refer into an ARM. It is just like any other meeting. You arrange, you send the invite out, you get the people buy into that meeting. It's the second bit that you will need to use a toolkit, but we'll talk about that in a moment. So you do not need to refer into an ARM. There's no required referral process. It's not like other processes that we have within our county, such as Marrickle Prevent. You don't have those forms, that requirement to complete and send in. It is instigating that meeting through inviting professionals. So how do you document the ARM? And this is where you may need or feel that you prefer to use the ARM toolkit. But you can actually use any method to record your meeting. So it's no different than those of you that might attend a core group, or you might attend a MARAC meeting, or any of those other methods. You will have a way of accessing and recording that data, that information. But there is an ARM toolkit which can be accessed via the NSAB website. I have put in the link there, but if you just put in ARM toolkit Northants into your Google or other search engine, it will bring up that toolkit. You can print that off. That gives you a pro forma to record that meeting, such as who's in attendance, who wasn't in attendance, what information was shared, and it gives you a space to complete an action plan, who's to carry out that action plan, but it also gives you the risk assessment, etc. at the bottom. So once you've captured that information, make sure that you get the risk level. So when you have your initial ARM meeting, you must establish the risk. And again, it's a matrix that's at the end of the form, and it looks quite confusing, but I think once you get your head around it, it's not as confusing as you think. But we need that risk level in place because that is your starting point. As we know, risk is fluid, it can go up and down, it can change quickly, it can change over a longer period of time, but we need to capture that within the ARM process. It can also help you establish whether an ARM is still required. Once you've captured all that information on your toolkit or in your other method of recording that meeting, send out those minutes with the detailed action plan to all the participants of the meeting, but also to those that weren't in attendance, to all those professionals that you feel would benefit that information. So I've put GPs on there, but that GPs are not the only ones that will require that information. There's many services that can't always attend every single meeting, but will require that information to support their patient or their customer, the individual. So why is ARM so important? With an ARM, it's a very much person-centred approach. It helps keep the focus on the individual. And as we've said, if you've got the individual in the room, that also helps you keep that focus. We are there to talk about that individual, what they need to support their situation. What can we do as professionals to support that individual? And that is the person-centred approach, keeping them at the middle of everything that we're doing. We need to involve them in their risk management plan. There's no point any one of us putting a plan into place if we have no engagement and no input from the individual. We may not always at times have that engagement from the individual. Again, as we know, people's lives, they can dip, they can go up, you know, they can be in good places and bad places. But ultimately, we need to involve them in that plan. We don't want to be setting up people to fail. That is far from what we should be doing, but we do need to keep that person-centred approach. It's so important. The voice of the individual is absolutely paramount when making decisions that involve them. Like I've said, if we put a plan in place, but we have no input from that individual, they're not going to follow it through. It's just going to fail. We want to empower the individuals that we have and ensure that they have a level of control over what goes on in their life. And as we know, very often control is taken away from some of the individuals that we deal with, that we work with, that we support. And the best way to support our individuals is by giving them that pat on the back and supporting them to make the decisions that would benefit their long-term safety. So agencies are sharing information. So obviously with ARM, it's about sharing information. Sometimes through no fault of our own, we work in our silos and we don't share that information. ARM is another opportunity for us to share that information about that individual and building up that bigger picture of what is going on for that individual. We all get different little snapshots of what is going on, but when we piece it together, sometimes the story is not as it seems. The sharing of the risk and are involved in the risk management plan, so we're all aware of what we're all doing, so we're not duplicating, we're not exhausting our individual, we're not having 10 people trying to do the same thing when actually one person who's in the best place can do it. So risk assessment and plans are an essential part of the work that we all do. We all do our own plans within our own individual roles. This one is through the ARM, so it is documented and it has to be reviewed and it has to be risk assessed. So we've put together a couple of case studies. So I've got one that I'll go through with you. I won't go into all the detail that's on the slide, but this is a case where Kettering General Hospital instigated an arm for a lady who was known to our midwifery department. She was actually due to expect her 6th child. She was known previously to services, and she'd had 5 children removed from her care previously. This individual, so Susan, wasn't engaging fully with services. If she did, it was really sporadic. It wasn't all the time. And it was also believed that she was putting her and her unborn at risk for actually quite significant serious harm. So when we looked at her situation at the time of the, just prior to the arm, she was 18 weeks pregnant. She had already planned a termination. She had mental health concerns. She'd had previous suicide attempts. There was self-harm. She was currently denying the use of substances with her, but it was actually known to some services that she was in fact still using those. She actually came into Kettering General Hospital whilst pregnant because she'd taken an overdose of medication. Whilst she was in the hospital as an inpatient, there were also concerns that she had actually gone round to other patients and was taking their medication. She was also picking up other babies, and as you know, within hospitals, you don't pick up another person's baby, and certainly wouldn't do it without consent. So some of her background, and this is where some of the risk, well, it is where the risk comes from on top of the most current situation. So she was known to have a history with the police. She had many convictions. One of those, which was concerning for us, was the arson. She was also known to have supplied drugs to others and to her own children. There was a history of sexual assault on another person. She had in fact cocooned a vulnerable adult. This adult then did end up in hospital with us due to what this person had given them. So like I've said, there was multiple crime types. She was known heavily to the domestic abuse services as a survivor, but also as perpetrator. But overall, she was known to be a risk to others, so adults and children and other vulnerable adults. So part of the action was, so due to the current pregnancy of Susan and the concerns that we had, we thought we need to raise an arm. We need to get all these other professionals involved to attend, share their information and put together a robust risk assessment. And ARM gave us that ability to do that for this young lady. So we sent out invitations to our local authority adult safeguarding team. We knew that this lady had a probation officer, and we knew that S2S were also involved. Obviously, the named midwife for safeguarding at Kettering General was the lead within this, so the safeguarding adult team also became involved within the hospital. So they were the key services at the time that we were aware of, that we knew were involved with this lady. As the invites went out, we had support from all of these services. They did attend. And at the ARM meeting, as you would with any initial meeting you would have, we went through why we were holding the meeting, what the concerns were, and what we were hoping to achieve. The history was given regarding this lady, because obviously it's quite concerning, quite a history, shall we say. So information and risk concerns shared by those in attendance at this ARM meeting. And it was agreed that it did meet the threshold for an arm, because sometimes it's not always clear at the start, but actually in this instance we knew from the start it would do, but we got clarity from other professionals who shared that concern. But also using the risk scoring and grading matrix, it helped us to highlight the level of risk. So we knew that this lady, her baby, and the person that she was currently residing with were at extreme risk for their own different reasons. So we've got 3, we had Susan, we had the unborn, but we also had a vulnerable adult who she was living with. So we actually risk assessed those 3 situations, and it was deemed extreme risk. Risk was, it's already on here, so risk was considered for Susan to her baby, but also the risk she posed to others because there was quite significant history. It was agreed that the arm would then be managed by probation in the long term. As just literally prior to the arm meeting, this lady did attend the hospital. She did have a termination of her pregnancy and she was discharged. So at that point, the safeguarding midwife had no further input with this person. So it was deemed that the probation officer who would be working with her for the next, I think it was at least 8 months to a year, it was felt that she was the best place to continue the arm. Adult social care at the time hadn't had much input, but it may be that that then moved over. But probation initially for the second meeting took the management of that. So the minutes were typed up by us within the safeguarding team, as you would with any of your other meetings that you would hold. They were shared with all the professionals in attendance, but we also shared them with those agencies that couldn't attend, and a further date of the arm meeting was set.
Thank you. So I'm going to talk to you now about a case where we instigated an arm here at Northampton General Hospital. And this was for a lady we shall refer to as Nadine. She was under the care of maternity services and she was expecting her first child. She had known vulnerabilities. She hadn't been engaging with services. Engagement with services was sporadic, and there was a professional concern that she was putting herself and her unborn baby at risk of harm. So this situation that she was 12 weeks pregnant when she came to our intention. She had mental health concerns, anxiety, depression, self-harm and suicidal ideation. She herself was a victim of childhood trauma and sexual abuse, and she had sporadic use of illicit substances when she was under the influence of alcohol. And so she wasn't addicted to any particular substance, and even her alcohol use was sporadic. But when she was under the influence of alcohol, her behaviour changed quite significantly. And she first came to our attentions when she attended Northampton General Hospital for an appointment. So she was under the influence of alcohol at that point, and she became very abusive and aggressive towards the staff that were providing care for her. So much so that they had to, staff that were on the observation area that she was in, had to lock themselves into a room and call for the support of our security team to come and help manage her. So her sort of background around Nadine was she was open to probation services, as I said, because of this volatile behaviour under the influence of alcohol. She had assaulted mostly sort of health professionals or the police when she was under the influence. She was open to mental health services in conjunction with her GP and mental health treatment plan through probation services. But due to sort of the lack of engagement, no real meaningful work had been able to be instigated with Nadine because of her issues with alcohol and substance misuse. She was a victim of domestic abuse, and she'd had a significant history of being street homeless. And although she had moments of times of being temporarily accommodated, she had real difficulty adapting and managing a tenancy. So when she was visited by midwifery services at home, she was really living as if she was still street homeless, sleeping on a soiled mattress that she'd found outside in the street that was soaked with rain. She helped the property that she was in was brand new. It'd been recently refurbished, but she was it was heavily littered with rubbish. She wasn't able to keep it clean. She was extinguishing cigarettes on the floor in the home. So there was an issue, concern around her sort of safety and potential risk of fire. She was also, when she was temporarily accommodated, I think because she had been used to being on the street and being within those communities in the street, when she was housed, you know, in order to reduce her risk and improve her safety, she actually really struggled with the loneliness that she was experiencing while she was in the property, and she was very vulnerable to groups of male gangs who would come to her property, especially if she had received her benefits. They would then encourage her to buy alcohol, and then would give her illicit substances and then use her for sexual exploitation. So she was extremely vulnerable, and so even in that situation where she had been, you know, something had been put in place to improve her situation, actually that in itself became an additional risk. Thank you. So the arm was instigated due to the concern for Nadine and her unborn baby. Professionals included in the arm were both adults and children's social care, probation services, GP, mental health support, S2S, she was open to them. Obviously, as I said, housing were involved, and maternity services, and also her family members. She had really supportive family, really supportive mother and sister. However, due to her volatile behaviour when she was under the influence, those relationships had really broken down. They still were very concerned about her, obviously loved her dearly, but they were finding it increasingly difficult to support her because of her behaviours towards them, and the risk that she posed also to their wider family, their own children. She had a younger sibling in the household, so it became that those relationships had really broken down, and they were at a loss how to support her moving forward. So it was really good to have them included as part of the arm. There's also charity services that were supporting her. So regular meetings were held. Obviously, the history was shared and the professional risk concern was shared by everyone in attendance. And the grading matrix was used to review that level of risk at every meeting. I think the really beneficial part of the arm is the perspective that you're able to gain from other professions that you may not have considered in your own profession, and how that can alter the level of risk, and also having that perspective shared with that individual from all agencies, I think can be really, really powerful, because often, obviously, when individuals are making decisions, they don't see that risk from a professional perspective. So I think it's just a really, really good opportunity, as Fiona said before, not to be working in silo and to consider those that wider MDT risk perspective. So because of the risks posed, it was categorised as extreme risk, and that was a view agreed by all professionals. The action plan was created, and it involved obviously drug support agencies, mental health treatment. Everybody who was part of the invited to the arm had an actions on the plan. What has started to happen was improved engagement with services. Things like, for example, supported accommodation was secured for Nadine, so that she then didn't have those periods of loneliness where she would reach out or became more vulnerable to those risky adults that were targeting her, so that she had other people around her, and it helped with her adaptation to living from the streets to accommodated property. She began to engage with mental health services better, we were able to put a plan into place because there were concerns around risk of overdose when she was under the influence of alcohol with her mental health medication. It was a plan was devised for that to be delivered to her on a daily basis. She was also seen at home, so she didn't have to go into town, which was a real trigger point from her. So it was just that way of ways of being sort of creative around engagement and looking at her as an individual.
Jo, you've gone back on mute.
Sorry, I don't know how that's happening because I haven't touched my mouse at all. Sorry. So where did I get up to? What did you hear? Were you up to?
You just mentioned about engaging with her at our house rather than her having to go into town.
Right, yes. So that was as we looked at some kind of coming up with creative ways to ensure that she could engage, because one of the triggers, one of the risks was her going into town and mixing, and it was a trigger for her for drinking. So it was just kind of trying to avoid things like that for her to best support her. So as her engagement improved and the meetings continued and the grading matrix was reviewed at each meeting and the risk actually stepped down. There was a child protection plan that had been initiated in respect of her unborn baby. So there were still regular meetings with the professionals that are around were supporting Nadine. And so then the core group meetings were taking place regularly with an action plan, a child protection plan in place. So they were in effect, we were able to discontinue with the ARM at that point. The baby was born and was placed in the care of maternal grandmother. And I think that really was something that the ARM helped to facilitate, because they were part of that process and they were able, supported by professionals, to then still be that support, provide that support network for Nadine, which as her relationships with those family members improved, that gave her the incentive to keep going and to make those changes that she wanted to make, not just for herself but for her unborn baby. So as I said, the baby was kept within the family, which meant the world to Nadine at that moment, because she still wasn't in a place where she was able at that point to care for her baby independently, but she was able to have regular contact facilitated by the family. And I didn't ever have, once she, obviously at the end of the postnatal period, I didn't have any further involvement, but things were looking very positive at that point. Thank you.
Okay, so we just wanted to share with you some of the resources that are available to yourselves that help you in regards to not just only the ARM process but other processes as well. So this is available on the MSAB website. So you've got the interagency policies and procedures, the decision-making framework guidance, self-neglect guidance, and the ARM guidance, and they're accessible to all of you. There's also, just to make you aware of the ARM oversight panel, for those of you who are not aware of that. So if you needed further advice and guidance, so this is if you happen to not necessarily get stuck, but if you're really struggling to either get engagement, or if you just feel that the ARM process isn't progressing, that you can actually refer into the oversight panel. So this does actually need a referral. And they will offer you support and guidance on how you can progress with the ARM. And I think it's sorry, Chloe, just jump back to the last one, apologies. Just to remember that you shouldn't delay. It's important that if you've got significant concerns about individuals that you're supporting, that you do instigate that ARM process. You may not be the agency that carries it on or the individual that carries it on, but if somebody is at serious risk of harm, then that process needs to be triggered. Thanks, Chloe. So some further resources I've just touched on the Safeguarding Adults Board have launched and also the ARM toolkit on there, which has all of the information that will help support you with that adult risk management meeting and the process around it. And there's also a video available on there as well that gives further support and guidance on the ARM process, and also as well as we just talked about the ARM oversight panel. And I think it's just to reiterate, and we all know this, but safeguarding is everyone's business. We've all got that individual responsibility to raise safeguarding concerns when you feel that an adult is at risk of harm or abuse. And just to be, just to highlight that it's everybody's responsibility, but never assume that somebody else has done it. Better to duplicate it than not submit it at all, or to raise your concerns. And if you're in any doubt at all, report it. Thanks, Chloe. Okay, so just wanted to ask you, have you got any questions, observations, any thoughts? It's up to you if you want to put anything in chat. I haven't actually looked at chat. I don't know if there's anything in the chat at all, Chloe, at the moment. But if there was any questions that any of you had that you wanted to ask, oh gosh, here we go. Sorry, what I did mean to say was you can either put your hand up or you can put it in chat, whatever you feel more confident about.
Hi, sorry, I was a little bit late to the meeting. I do apologise. I was caught up with something, so you may have said this at the beginning. I'm Lydia from S2S. Hi, I just wondered, is there any chance of us getting the slides or some information? Is that possible?
This is being recorded, Lydia. So this will go on to the Northamptonshire Safeguarding Adults Board website.
Thank you.
I'm not sure when it will be available from, but it is being recorded and it will go on there, and all of the slides obviously will be available on there.
Okay, thank you.
No problem. Anybody else got any questions they'd like to ask, or to ask either Fiona or Joe about the case studies that they've kindly shared, that obviously adds that tremendous value to this process? No, was there anything in the chat at all, Chloe? I haven't looked, sorry.
No, there's no
Okay.
comments in the chat.
Okay, so we're going to open the floor to yourselves again then. So could we move on to the next slide, please? So what we've done is devise some frequently asked questions. So these are questions that we all know have been asked. Some we've already covered through this session, but we just wanted to open up to you. So it's up to you whether you want to raise your arm and answer, or whether you want to put your answer into the chat. So can we please ask, who can start an arm? Does anybody want to answer? Does anybody want to put it into the chat? Anyone, absolutely. I can see them coming through in the chat. Thank you so much. Yeah, anyone can start an arm. Anyone. Okay. And how do you start an arm? What do you need to do? Any service with a concern? Yeah, thank you. Anyone can? Yeah, sorry, moving on. What do you need to do to start an arm?
Come on, someone must be able to speak up. It gets very boring listening to our voices. So please, anyone, put your camera on.
It's all in the chat. It's all in the chat.
Nobody wants to speak though.
Calling a meeting, yeah, arrange a meeting. Absolutely. And I think what is essential is what we talked about previously, is that initially you might not know all of the individuals, the professionals, the voluntary services, all of those wonderful specialist services that are around, are available, who are involved in that individual. But if you invite the professionals that, those other services that are involved, then it adds that further flavour that all of those other services can then be invited. And I think that's what's key. It's that initial trigger, and then all of the other services that you think could be may need to be involved can then be involved in that process. And essentially, and I think Fiona touched on it, essentially, who is the most important person, or who has that engagement with that individual? Okay, so
Yeah, I'll speak up, nobody speaking. I just wanted to add that, yeah, absolutely, from what you said, it's not just a professionals meeting, is it? Because
No.
that doesn't involve the individual. And I think it's really important that the best arms presumably involve the individual, because they need to work with us and know what the support's there and to get the best outcomes.
absolutely, outcome focused. It has to be about the individual, but as we know, and I think we've already touched on it, and we all know that not every individual wants to be involved, but it essentially the priority is that they are involved in that process, and working with them about their risk enablement planning. Okay, so do you have to refer into an arm?
No.
Rapid response. No, you don't have to refer into an arm. Anybody can trigger it, but there's no referral process. You start that process. Should adult social care start the arm or manage the arm?
Now, I know there's some social workers on this training. Anyone dare speak up?
I'll speak up. I think, yes, sorry.
Especially with the person that was worst, first concerned.
Yeah, knows. Absolutely. It's who's involved with that individual. Who is the most appropriate agency? Who should lead on the arm? And it isn't always necessarily adult social care. There's other organisations and voluntary sectors. You know, there's lots of different organisations that would be involved and would be most appropriate to manage and lead on that arm. Social care, you know, probably should be invited to that arm, because obviously you need the support of that multi-agency approach, but not necessarily lead. So who should you invite? I think we've touched on it, but we'll just ask the question again. Who should you invite? Yeah, thank you, Lydia. Anybody who's involved?
Or presumably you might think would be useful to be involved.
Absolutely. Who might, and also who might be able to signpost you to another agency that they feel that should be involved as well, that you're not aware of, I think is essential. Yeah. Do you have to use the ARM Toolkit pro forma? You don't necessarily need to, but it is advisable that you do use it. It gives you a good framework, I think, to utilise it. It's in the pro forma gives you a good guide of what the minutes, you know, you can add that separately, but it's important that is shared. But the toolkit is there and the pro forma is there for you to utilise and guide you through that ARM process. What happens when a service won't attend the ARM? Anybody willing to share? Anybody willing to say, put their hand up and say and share?
Just I might have a bit of a guess at this. I suppose just encourage them and say the benefits of it, but also document their reasons why they haven't, you know.
Yeah, absolutely, because I think the thing is that not everybody is aware of what an ARM is, and we know abbreviations. We all know within our field of work that abbreviations mean many different things, and I think it's just understanding what that is and what the importance of that professional or, you know, voluntary or other sector, what the importance is for them to attend that meeting and the value that they will add to it as well.
Hi, can I just ask a question? It's Catherine Martin. I'm from Adult Social Care in Northampton. I'm just a bit confused, or just wanted a bit of clarity in terms of what you were saying about that we don't necessarily have to use the ARM toolkit, the pro forma, because my understanding is that we would really need to use that, because that's where your grading is, and it's important to kind of keep, I guess, from our perspective, is the risk enabling and the recording consistent.
Absolutely.
So
No, I
we
think-
tend to always use it, or
Yeah, I think that the importance is that it is used, but I mean in regards to minutes of the meeting, that you can record additional minutes as well, Catherine. That's what we were trying to point towards.
okay, yeah, no, that's fine. Thank you.
No, no problem. Thank you. Okay, and the final question that we have is what happens when the ARM process is stuck and you're unable to progress any further? Anybody?
Take it to the oversight.
Yeah.
Sorry, I missed that. I beg your pardon. Sorry.
Contact the oversight panel.
Yes, absolutely. I think if you really get stuck and you really can't progress it any further and you're, concerned about that individual's that significant risk, then it is about referring to that oversight panel. But I think it's also the other thing I wanted to just, we wanted to highlight was just around if somebody is at significant risk of harm, it's also about being, obviously aware of other, you may need to, call 999, you may need to refer to other services as well. Yeah. Is there any other questions that anybody has? No? Okay, I think Chloe's just put the last slide up for us, which is obviously just a reminder, thank you again all for attending, much appreciated, and thank you for your input as well, it's really helpful. Just a reminder, just that if you can complete the certificate, the evaluation before you leave the session or after the session. And also, if you want a certificate, you need to complete the evaluation as well. Thank you all so much for attending.